for occupational health, but also works in a commercial occupational health provider, where she is, for obvious reasons, very engaged in governance, training standards, and the use of tools within that commercial provider. I'm hoping we'll still be joined by Euan McComiskie. He's a very experienced physiotherapist who specialised for very many years in the area of particularly informatics and tools being applied in the physiotherapy space in this area. He is hopeful to join us, but has had a bit of a family emergency at the last minute, so he's not currently on the call, but we'll pick up with Euan at the point at which he comes in. So I'm just going to start by throwing it out there to Janet and John, as it were, and to say, look, the title of our webinar is "Can AI Improve Occupational Health?" And it's one of those things that it's a bit like Marmite. People have very strong views one way or the other. And I guess the question is, good thing or bad thing? And I'll throw that to you, John, to start with, and then bring Janet in.
Okay. Well, thank you very much, Steve, and good morning, everybody. Fortunately, we've just been doing some research on this. We did a big poll of occupational health professionals on their experience of using AI tools in either their occupational health consultations or in their report writing. And the sort of message I'm getting back is it's a bit of both, really. I mean, there's no doubt that the UK occupational health market is stretched, and there's a recent government report that shows that most services are working at capacity and they can't recruit people to expand. But certainly we're seeing 60% of commercial occupational providers are already using artificial intelligence in their consultations and report writing. And what that's doing is it's reducing the amount of time that clinicians are having to spend on administration, which clearly frees up time for their perspective to bring in more business, make more money, etc. Arguably, it might also free up time for the clinicians so that they can do more high quality consultations, spend more time keeping up to date with the research, having more time just to develop personally and professionally. So the question is whether the balance is correct, isn't it? So if we use AI just to make the treadmill go even faster, but getting more and more consultations done, then all we're doing is lining the pockets of the business owners. But if we're using it to facilitate the professional to do a better job, to do a job more comfortably, to feel better informed as they're doing it, then it's a great thing. So I think, I really welcome the technology, but my sort of conclusion from doing the research is that we need to make sure it's rolled out effectively so it supports everybody who's involved, the employers that are commissioning the services, the providers, so that they can run a successful business and increase OH capacity for the nation, if you like, but also the professionals to make sure that they aren't just getting more and more work thrown at them, but they can actually do a more professional job because they're getting the support they need.
Thank you, John. Janet, from your perspective, good thing or bad thing?
I think it's very much from what John said. It's an absolutely good thing if it's used correctly and doesn't lose that human touch, and we don't lose our ability to critically think. Also, as John said, if the workload then becomes too excessive because of the use of AI, then actually it's no longer going to be of benefit. I think within occupational health, we always have to be thinking about the health of the workforce. Can we use it to improve the health of the workforce? And if we can use it to remove those administrative tasks, which is the most common way people are looking at it. And John mentioned, obviously, consultations, so scribes, taking notes, maybe helping to start that report off. And in some cases, providers are using that to actually build the report, and allows us to have more time to be spending with that individual, asking more in-depth questions and getting a better output. Then absolutely it's a good thing. But I also think that it's a good thing in that we have to keep up. We cannot be behind. The rest of the world is going down the AI route. So and I'm sure, John, you found that from your survey, because the surveys, we've done as part of the AI and OH group, although the second survey, we haven't got the outcomes, is that there is still a lot of fear. So if we are not doing the research into actually what can be that impact in order to lead to that balance, then we're going in blind, and we can't go in blind. We've got to go in with our eyes wide open and understand the implications.
So I guess, Tanny, just to come back on that, the point is whether the practitioners are being consulted in the rollout of the technology, or even, for some organizations are actually designing in-house systems. Well, are they speaking to their practitioners to make sure that the technology is, being good for them as well? So if we're not involved as professionals, then, we're going to end up with a system which is not fit for purpose.
Well, and even more controversially, John, whether they actually know that the technology is being applied in the systems that they're actually using.
Quite.
That is absolutely an excellent point. But yes, every organization that's using AI should have an ethics committee, and there absolutely need to be clinicians on that ethics committee. And I think that it has to be trialed and piloted with clinicians in order to make it effective, in order to make it work. And I have heard of people that have said, well, we're using AI, but actually it's added because if it's not, because we all know that, AI can not always be 100% right. And there can be gaps in there. There can be fabrications or hallucinations. So you've got to go back and check it. And if that checking creates extra work to go in and redo it or to rewrite, etc., then that could be adding that extra load. And something I think that the HSC brought up at a recent meeting was actually we've got to be thinking of the implications on the individual that's using the AI, the health implications of the person that's using the AI, not just the implications for undertaking the work. It's a dual perspective that we've got to be looking at. And not just us, obviously, we've got to be thinking about the workforce that's out there that's using AI that we're supporting.
So I'll return to that issue about the impact on the people in a few minutes or so. But I guess I was chief examiner for the diploma in occupational medicine for 19 and a half years.
Wow.
And across that period, I saw a number of portfolio submissions that were clearly plagiarized. And recently I've been doing some marking for you, John, and your team. And I saw two submissions, both from a specialist organization. One of them absolutely excellent. The other one pretty ropey, to be honest. But I found myself thinking, well, has that excellent one been generated using AI? And if so, is that wrong? Because basically I wasn't penalizing candidates for actually using a word processor or a spell checker. And is it any different from using a very clever type of pen, John? You must see this in your...
So long as the output is good, I agree with you. I mean, I had the same, I mentioned to you in private, we've had one or two things where references are just turning up that don't exist. And, you think, okay, well, I don't mind you using the technology to source the literature you want to read, but make sure that it exists, and B, it's applicable to what you're writing about. And as a note of caution, I wanted to mention an important court case, and I can't remember the name of it now, but I sit on the Employment Tribunal Service, but we had a note from the presidents of the tribunals warning about the fake use of artificial intelligence. And what happened was that there was a case that I think in the High Court where two solicitors had prepared case briefing, and they'd used artificial intelligence to come up with the cases, except these cases didn't exist. And the really foolish thing was that one of the cases cited the trial judge, even though this trial judge had nothing to do with the case. Now, what's really important for professionals is that one of those solicitors was referred to their solicitor's regulatory body, which could mean a sanction or a suspension. Now, again, if we find practitioners are using this material, these tools, and they're creating evidence which is wrong, well, maybe that has some implications for their professional practice. So that is a word of warning from the legal system.
And where do you see things sitting in the training curricula, Janet, in terms of, because clearly there is a responsibility on training providers to ensure that they do teach people how to use these tools responsibly and ethically, as we've already touched on?
It's an interesting question, and I really was fascinated by the fact that there's 3.5 million being put into AI research for PhD candidates in their dissertation in using AI effectively. So it's definitely the way we're moving. But I do know a lot of educational institutions that are saying you can't use AI. And I mean, I've certainly recently completed a higher education qualification, and we were told that it was going to be assessed for the use of AI, and AI was absolutely banned. So I think, and certainly a number of the educational institutions around occupational health that I speak to, they're doing that. But you're absolutely right. Even CVs that we see coming in, you can see that there are some things that you can spot if people aren't clever that show you that it's been written by AI. And it's an interesting concept because most people I speak to see the use of AI in education as being a negative thing, but actually, if it's used correctly, you have to do the prompts, you have to put it in. It can really help you find that evidence. But there are so many times, and I've used it once to be able to get some evidence for myself when I was doing a bit of research, and went into that evidence, gave me the links, went into those links, and not one of those links said what AI was saying. It just wasn't there. So it has to be checked. Everything that you do has to be checked. And I suppose that puts a bigger onus on training and education, because now they have to double check what people are putting in, and that's more time consuming.
And I think that is the key point, isn't it? It's training people on critical evaluation and critical skills. I was very struck by something that Euan actually said in our pre-meeting before this panel discussion, and it links into the point that you were raising earlier on about how this is changing practice and changing the way in which practitioners are building up their skills and experience as time goes on.
Yeah.
And at the end of the day, a lot of what we do is very nuanced, and it's often what's not said that actually helps you understand when somebody's got a particular problem, than rather when things are said, which is picked up by the technology. So I wonder if there's a real risk that we're actually de-skilling some of our practitioners in their ability to have that sixth sense when things just don't quite fit the normal pattern at the end of the day.
I suppose it sounds like, Steve, that ideally we want people to learn all the skills, and then once they've learned all the skills, then to switch on the AI so they can enhance it. But the problem is that that isn't going to happen in practice, is it? Someone who's entering the profession now, perhaps we've brought up on more technology, is going to be bang straight in using the technology. So how are they going to get those skills that you're talking about?
Yeah, and I'm very struck by by Euan's role within his professional body. I'm not sure we actually have some of these roles but we certainly have them in terms of ethics committees and things like that. But I'm not sure we've got specialist leads in this technology actually working directly within some of the colleges and some of the organisations that we are relying on to regulate this marketplace. Is that a concern, Janet?
I suppose I just want to go back to that point about losing that critical thinking before I move on to this point. But certainly one of the big providers that are using AI have openly said that they had noticed that their clinicians, and here's Euan, bang on time, they had noticed that their clinicians were starting to just accept, and they'd picked this up through audit. So they were doing a lot of audits on the work, and they were able to go back and educate their clinicians on making sure that they that the importance, if you like, of having that critical overview of what they were putting out. And I suppose that's where it comes into John's point of it could end up in court, and therefore why shouldn't an OH report be interrogated just as much as anything else for factual accuracy. So yes, that loss of critical thinking. And now I've forgotten your next point, unless I think it was about we should have a specialist to be looking at. And I totally agree. I think that's fantastic that there's physiotherapists have that.
I think one of the dangers, Janet, to pick up on that point, is that the technology is advancing rapidly. I mean, in our survey, we've got, as I said, 60% of providers, 35% overall of using AI already. Technology has only been around for 2 years. We are getting this massive change in occupational health, as in every walk of life, which is great. But we have to make sure that the sort of practical and ethical guidance, and even some of the legal guidance, is keeping up with that, because it's racing ahead. We can't produce guidance quick enough to keep up with the race in technology.
No, you're absolutely right. And the other point I wanted to pick up, which I think is really valid, is the fact that, like any graduates coming into any specialty, you learn by experience, and we've got to absolutely make sure that learning isn't affected by the fact that they're coming straight into using these tools, whereas they might not have before. And that's where I think training and education on it is absolutely essential, plus the guidance. And I know the Chartered Society of Physiotherapists are ahead of the game with already providing that guidance out there. And we're certainly building guidance at the moment as part of SOM and the AI and Occupational Health group, but obviously quite far behind Euan here and his team.
Yeah. And I think it's interesting that you say it's only been around for a couple of years, John. In fact, the first actual example of AI goes back to Greek times.
And also I think it was first postulated in 1948. It's true, but the large language models have only been around in very, very recent years. That's what's created this explosion of use. And before it was conceptual, it was in experimental stages. Now it's these are practical tools that you can have for free or buy for the more specialist ones. I just wonder, there's quite a few comments that are coming up in the chat. I mean, maybe we should be getting some views from others on this. I sit in my sort of academic ivory tower somewhere. I'd like to know what other people are thinking in practice.
So, Chris,
would you like me to read out?
I'm technologically challenged here, Vandy, but I can see that Chris has.
There's some interesting comments. Two particularly I want to kind of relate to report writing. So one comment about how we can use AI to not write the report, but write our clinical notes and collate that. But also then writing a kind of a note at the bottom saying this report was not using generative AI, was created not using generative AI. And I suppose the opposite to that is, which came up in the conference, Janet, that you ran on international occupational health and use of AI, where we should be stating AI was used to collate this data, or AI was used to collate this report, and I take full ownership for the content of this report. And there was some really interesting contracting around that, wasn't there?
Yes, absolutely. That was made quite clear that we ethically should be advising that we are using AI if we are using AI. And of course, that brings up the consent question as well. If we are using AI within a consultation, we really...
Can I just come in on that, Jenny? Because we asked this question, and actually only of those people using the tools in this context, only a third were informing the client that they were using it. Well, we actually said client or employee, but it seems that only a minority are doing that. And we had one or two comments on this, and one of which was, well, I don't give any confidential information to the AI tool, so there's no need for consent. So I'm not sure where we stand on this, but it's one that needs to be debated.
Yeah. And I think that's why the FOM Ethics Committee is certainly, and I know I can see that Hilary's on the call, so I'm being a bit cheeky here. But I think that's certainly something that's on the AI is certainly something that's on top of their thought processes here.
Hilary, I don't know if you want to come in on that as you take over the challenge of chair of the Ethics Committee. I know you've only been recently appointed, and without wishing to put you too much on the spot, but is it something that exercises you?
Yes, so we met just last Friday actually as a committee, and we're meeting again for a full day in October, and AI is definitely on the full topic of discussion for our October meeting. So the guidance is currently being updated, and with the requirement to get it online, just for everybody's information. And we're aiming to get a first draft of that online by November. The FOM, before I took on as chair, accidentally took on as chair, the FOM have committed to getting it online by November. So there'll be a sort of a fairly swift review initially, but AI, I suspect, will be one of those topics then we can update regularly. And the beauty of it being online instead of our hard copy green book means actually we can respond to these emerging themes. So it's definitely on the topic of conversation for October to debate, to put some initial guidance in, and then we'll probably, no doubt, update it as the world moves forward with this technology. Hope that's okay.
I see that on the call, and again, you may or may not wish to come in, but AI often mistakes me for Steve Foreman, who is on the call and clearly has led on behalf of HSE for some time. Steve, we talked right at the beginning of this call about accountability and liability. Is that something that exercises the HSE as services increasingly use this technology to deliver their main service offerings, particularly increasingly in the area of health surveillance, I think?
Thanks, Steve. So I'm just trying to negotiate Zoom. I don't normally use Zoom, so apologies. Yeah, thank you. And it's nice to come along to this. Sorry, I missed the first 5 minutes, so I didn't catch everything that's been discussed. So we're fortunate on the one hand in HSE from a legislative perspective. We've got the Health and Safety at Work Act, which is a goal-based piece of legislation. So if you think about what technology was in the 1970s, and I'm old enough to remember some of that. You can see how we've moved forward over the last 50 years, and we've recently had the anniversary of the Act as well. So the first thing, it is goal-based, but the second thing is, yes, you've got something new, and it potentially will create risk both for employees and for people not in employment. So from an occupational health perspective, obviously, you've got your own employees, you've got to manage the risk for them, but also when you're providing advice to duty holders, employers, you need to make sure that advice is not putting them at risk as well. So it is something that has created some debate, and we had a very useful meeting, and Janet was one of the people there last week, and on the whole discussion around this. I think certainly from a process safety, which is broadly where this sort of lands in the grand scheme of things, if you're going to create a system that does something that affects risk in the workplace, then you're going to have to own that risk. And that, going back to the Parent Act, the Health and Safety at Work Act, that's exactly what it requires you to do. So I think it is proceeding rapidly. We are learning as we go along as well, but there is some information on HSE's website in terms of some work that's been done in respect of AI. But I think the key thing is, it's like anything, if you're going to introduce something new, you need to make sure it does what you expect it to do, so it doesn't hallucinate, it doesn't have biases up front. In other words, when you program the AI, it's not inherently biased to do things in a particular way, and it needs to be properly validated to make sure you get exactly what you expect out of it. So we did discuss these things last week, and I think it's positive to hear that people are developing different things on the one hand, but I think perhaps John that touched on this earlier about developing things in isolation and not having a systematized approach to this to make sure that actually whatever you are doing isn't inadvertently creating risk and putting people at risk of harm. So it is something that's high on our agenda. It's something we are thinking about. It cross-cuts multiple sectors, as you might expect, because AI is used in lots of different areas, but one of those areas is, of course, occupational health.
Thanks, Stephen. Sorry to put you on the spot in that way. I see that Euan has now joined us in the background, and welcome, Euan, and I hope things are okay at home, and welcome to the conversation. Euan, we discussed earlier on that actually clearly a reliance on AI during training actually is creating practitioners who are differently skilled. And I know that your experience has been very much in the application of the power of things like health informatics and approaches like that can support those in training. Are you breeding a new generation of physiotherapists that are de-skilled?
Oh, what a nice, simple question to get started with, Steve. Thanks for that one. I sincerely hope not. I hope that we're breeding a new generation of physiotherapists who have a different skill set that is going to be able to allow them to deliver modern physiotherapy. Now, I want physiotherapists, whether they're existing physios or those who are new to the workforce, who are graduating now, I want them to understand the potential and the reality of AI. Just like I want them to understand the potential and reality of different digital technologies, just like I want them to understand the complexity of the human, conditions, just as I want them to understand a little bit about pharmacy, and I want them to understand anatomy and, all these other things. AI is part of their toolkit. And I want them to know when and when not to apply it. I want them to know when they can safely and effectively apply it, and when they safely and effectively need to be saying, this is something for the human mind. AI has limitations. I imagine we've spoken about quite a few of them already. Since I've joined, we've spoken about a number of them. AI is great at doing tasks and doing enormous, complex tasks that humans, not because we're bad, just because we're human, are inefficient at. AI started, its technical term is computational mathematics. It can do incredibly difficult sums very quickly, way quicker than humans can. But it's got limitations as well. Limitations where we can come in, because we cannot teach AI the sixth sense that a highly skilled clinician has about the human condition, about the patient that comes into them, about the customer that's in front of them. That's a human thing. AI can't do that. So, and I'll summarize. Are we developing a generation of de-skilled physiotherapists? I sincerely hope not. I think we're developing a new generation of differently skilled physios who deliver modern healthcare. AI could be part of that, but there are limitations on that as well, because health and social care is still predicated on human interaction. And until that changes, AI can't replace physios, nor any other healthcare professionals for that matter.
Thank you, Euan. I think that's very helpful. And I guess while I've got you sort of on the spot, as it were, you have had a senior role at the Chartered Society for quite a long time, leading on this area. But a lot of the, again, I'm not sure at what point you did join the call, but one of the observations that I think I made was that actually not all of the Royal Colleges or not all of the allied health professional organisations actually have somebody that has that level of skill and understanding to be able to hold their boards to account. How do you share the knowledge that the Chartered Society of Physiotherapists have been building up across that wider base, so that we're not cobbler's children being left behind in some of the smaller colleges?
Yeah, so listen, it's a really interesting point because, I've been in post at the CSP since 2018 in various different roles, but digital and informatics always throughout. I've been making an awful lot of noise about digital, about potential data, about informatics, about AI for an awful long time. So I try not to come from that I told you so camp, that this is something that we should have been focusing about. But AI is not new. John's right. What we know as AI, the large language models, your chat GPTs and other generative AIs, they are newer, but AI is old technology. We've been it really surfaced. Everybody thinks, that it surfaced out of Bletchley Park in the 1940s, but it's been happening for a very long time before that as well. It's just come more into the public awareness now. There's an excellent scholar, a person called Jessica Morley, who I'd urge you all to follow. I think she has some excellent points around about AI and around about the use of data in healthcare. And Jess will speak about AI being about 10 years away from being the next best thing in healthcare, and it's been that case for about the last 40 or 50 years. So we've never got to the point where AI is caught up with where we're at. Some people are further ahead than where we are just now. So if we think about radiographers within the allied health, family, radiographers at point of training are utilizing AI. The HCPC expectations of them as professionals are to have some expertise in AI, but it's not the same for everybody else. So we don't all have to be experts, but we do have to understand what the potential and the limitations of the use of AI should be. Yes, we're a wee bit further ahead maybe than some other Royal Colleges at the CSP, but and I'm probably not in danger of oversharing here. I'd like us to be further on than we're at, because we're always trying to keep up with where technology is, and it's an impossible task, but I want us to be a wee bit further on. I think we were quite late in publishing our principles for the use of AI in physiotherapy. I've heard already people saying that we're ahead of the game. I think we're a wee bit late. So there's always two sides to the story, right? And I said in the chat as well, I'm in a meeting next week where we're looking about the update for that as well, because it's a constantly moving feast. It's a difficult, complex thing to do, and particularly when we're working with our members who probably don't know everything about AI. And, full clarity, I don't know everything about AI either. So we're always trying to keep up. It's a constant thing, and I suspect we'll probably always be trying to keep up.
John, you're a publisher with a responsibility in this area. And we've heard several times, I think, in this conversation about misunderstanding, about fear, about stigmatization of AI, rather than it being seen as that fantastic tool to help us do our job better. How do you get rid of that fear, John, as a publisher?
How do you get rid of the fear? I think we mustn't focus just on the negatives. I think we should warn about the negatives, but actually we need to be talking about the potential. And I actually wanted to just come in on a slightly different point, because looking at the chat, there's been quite a few interesting discussions about the way AI is already being used in clinical note making, reports, all sorts of really helpful areas, and that's where we should be celebrating, I think. But I think we also need to look ahead. Euan was talking about always being behind. Well, we need to plan ahead a little bit here. If you look in the areas of recruitment, we're already seeing AI being used to sift through CVs, to help in the early recruitment stations. And we know the problem is that because the tools are being built by the knowledge that's out there, that they're already in building bias against people from certain cultural backgrounds, etc. I can foresee the temptation to use artificial intelligence in occupational health for things like assessing fitness for work, assessing whether somebody's meets the criteria for ill health retirement, etc., etc. We need to be thinking about those applications before the technology gets there, because we need to make sure that we're not in building certain biases against people. We're making sure we're taking account of all the things that need to be considered, which practitioners are already doing when they're making those real life human decisions about fitness to work. So I want to think how we're going to deal with that, not wait till it happens and then think, oh God, we better come up with some guidance and some advice. Let's think about how we get there and get there properly, practically, and equitably.
So Janet, if I can bring you in wearing your commercial provider hat. I know that you work in one of the largest national providers, and clearly it's a provider who are exploring the use of AI. And we've always had quite a fragmented marketplace with quite a large difference between the best and the worst at the end of the day. Are we not in danger of creating the haves and the have-nots in terms of who can use it and who can't in the marketplace? And are we going to leave the singleton practitioners behind?
Do you know what? That is a question that we've recently debated, that it's actually going to become exclusive and not inclusive, which is really what we want it to be. And I think that's just moving away from the PAM question, but certainly from the AI and OH working group, that's something that we're looking at. And there's been a strategic proposal to look at actually an inclusive AI agent, if you like, that can be used across anybody, any occupational health provider. But I certainly know from PAM, and I'm sure from Medigold and Health Partners and all of them, it takes a lot of money to build tools, and so therefore it does become there's definitely the potential to become exclusive, but also you've got to put your commercial hat on and say, if you're a provider, you're not looking at using AI tools effectively, then actually you're going to, and it's a very dynamic market, let's be honest. Occupational health is moving quickly, it's growing quickly, and if you don't keep up with it, then actually as a provider you're going to lose and you're going to get lost. So I think that there's something to be said for this proposal around having a universal agent for occupational health, where funding comes externally to support everybody, and just talking about the benefits of AI for everybody regardless. And one of the things that we've started talking about is auditing. So looking at overall auditing of services, overall looking at, obviously it's just ideas that we're exploring at the moment, looking at that against accreditation schemes, etc., because that way we could actually make it inclusive for everybody, as opposed to, and bring some consistency, start moving the parameters to a better standardization, if you like. So in that way, if we are talking about this and we carry on talking about this, then there is the strong potential that we could actually make it more inclusive and close that sort of gap between the bigger providers and the smaller providers. But
I think that's a very interesting point. If the bigger providers do take responsibility and are prepared to share, but we still need to remember that it's a source of competitiveness in terms of their ability to win business. And quite difficult to actually hand over your crown jewels in that way, perhaps in the open marketplace in the way that perhaps we would like to see in the future. Mandy, my AI is flashing at me to say that we only have about 5 minutes left on this call. I don't know if there are any key points that you'd like to bring out from the chat box, or anything, anybody that you feel we should bring in as we start to wrap things up.
Please, there have been a couple of points that would be interesting to just drop in, but I know Euan, you've got your hand up. So I'm just going to quickly say, just in case it's relevant for our last 5 minutes, interesting conversation about neurodiversity and neurodiverse clinicians, and how AI tools might actually help them create and write their clinical reports and their clinical notes, but actually who are they actually bespoke enough to be able to support people with neurodivergence. And then Chris Ambler has been posting some really interesting comments around the kind of the mental health side, and actually looking at it from the patient and the client or employees kind of perspective. And he talks about having strong quad rails in place, especially to protect the end user who might be more vulnerable. And I know we, Steve, talked about the days when patients would come into a doctor's clinic after looking up Google for a list with the list of symptoms and things and ideas what they think might be their diagnoses. And there's something about how we support the end users who've already gone into AI tools to work out what's wrong with them and how they can recover, and then come and present that, and how us as clinicians can actually be prepared and work with that and work with our patients around that. So it kind of links into some of Chris's comments around that too. So
thank you, Mandy. That's helpful. Euan, I'm sorry I didn't bring you in. Poor chair, I missed your hand. Can I bring you in there?
Yeah, sure. No worries at all. See, there's so much to talk about, isn't there? AI is such an enormous topic. We could be here till 7 or 8 o'clock tonight without even trying too hard. So I'll try to be really brief. We've spoken about AI and the potential that it could have. AI, as it is at the minute, the technology only allows it to be as good as where we point it. It cannot think completely independently. We have to point it. That's where the human bit comes in. We need to point it to the tasks that we need it to do. We need to give it guardrails of the things that we want it to do, the limitations that we want it to do. It could be potentially a great support to neurodiverse clinicians to be able, to support them to do their job in the best possible way, but only if we use them as part of it and get them to help us to point it in the right direction. Because I can't appreciate that because I'm not neurodiverse. But the people who are living with neurodiversity are able to point it in the right direction. And it's the same for all of the tasks that we could use AI to do. There's been a really few interesting points around about risk and around about bias. And we have a really uncomfortable relationship with risk in health and social care, don't we? Because it's different than outside of that kind of bubble. Because inherent, we can't take too much risk because we're dealing with human lives. But AI is different as well. We talk about the bias that it could introduce, and it's a really important thing to do. But our human services have inherent bias as well, because we are humans, and we can try not to make assumptions about the people that we're dealing with, but of course we do because we're human. So we can't set unrealistic expectations of our AI that we don't have of our human services. When we were writing the CSP AI principles, and this is a bit of full clarity, there were talk about an AI device that is found to have inherent bias must cease to be used immediately. Now, if we applied that same principle to our human services, we'd have nothing left. All of our human interactions are inherently biased. We can do better to have less bias and to understand and to seek knowledge of our bias, but we cannot remove it. So we can't set unrealistic expectations of AI to do that for us. We want human services. So,
isn't that the point of it, that we want these things to be better, to make progress? Surely we can say we want to reduce the sort of unacceptable bias that we have in so many human systems.
We can use it to be better, but we can't expect it to be perfect, I think. So it's the realistic expectations of it. I'm going to go back to my favourite/least favourite quote from the NHS England 10-year plan, particularly around about AI, where it says it will bring back the joy to work.
Oh, yeah.
Now, if we set that as our expectation, then we are going to fail. That's with the greatest respect to our colleagues at NHS England, but if that's a high bar, then we're only ever going to fail. It cannot bring the joy back to our AI. Can't even understand joy. It's a human concept. But if we set that as the bar, we're going to fail. We need to understand it so we can set, more realistic expectations and enjoy the potential of AI to do things in the best way, the safest way, the most efficient way, but not try to aim for perfect, because it ain't going to happen.
I think that's a very good point to actually wind up on, Euan, and give you the last word on that, leaving us thinking about the 10-year plan ahead and the changes that are going to face healthcare generally going forward in terms of meeting future need. Thank you to colleagues who've made today possible. Thank you to those who've joined in the audience. I hope you found it as interesting a discussion as I have. So thank you, John. Thank you, Euan. Thank you, Janet, and thank you, Mandy and Nicola and Anna, for organising in the background. I'll give you back the rest of your day. Goodbye, all.
Thank you, Steve.
Thank you, everybody. Bye-bye.
Thanks all. Bye-bye.